A rare heart defect. Single ventricle with double inlet. Single ventricle defects are among the most complex congenital heart defects. They occur when the heart fails to develop into two distinct pumping chambers, leaving only one functional ventricle to circulate blood throughout the body. In single ventricle with double inlet, both the left and right atria connect to a single dominant ventricle. This condition presents unique challenges, as the single ventricle must handle the workload of both the left and right ventricles. Understanding the intricacies of this defect is crucial for effective diagnosis and treatment. Echocardiography plays a vital role in visualizing the heart's structure and function, providing critical information for guiding patient care. In this study, we'll delve into the echocardiographic findings of a patient with a single ventricle with double inlet. We'll break down the observations, explaining their significance and what they tell us about the patient's heart condition. Our journey through these echocardiographic images will offer insight into the complexities of this rare heart defect and its implications for the patient's future. Let's begin by examining the findings related to the left ventricle, the primary pumping chamber in a normal heart. The echocardiogram revealed a morphologically left ventricle. This means that although it functions as the main pumping chamber, it possesses structural characteristics of a left ventricle. A striking observation was the presence of a large ventricular septal defect, or VSD. The VSD, a hole in the wall separating the heart's lower chambers, allows blood to flow between the left and right sides of the heart. In this case, the large VSD further complicates the blood flow dynamics within the single ventricle. Adding to the complexity, the left ventricle also exhibited moderate global hypokinesis. Hypokinesis refers to reduced contractility, meaning the left ventricle wasn't pumping as strongly as it should. This weakened pumping action can have significant implications for the patient's overall cardiac output and ability to deliver oxygenated blood to the body. Now, let's turn our attention to the atria, the heart's upper chambers, and their role in this unique cardiac anatomy. Despite the significant abnormalities in the ventricle, the echocardiogram showed both the left and right atria to be of normal size. This finding is noteworthy because in some complex congenital heart defects, the atria may become enlarged due to altered blood flow patterns and increased workload. The normal size of the atria in this patient suggests that, at least at this stage, they are managing the blood flow without significant strain. However, it's essential to monitor their size and function over time, as changes could indicate a need for intervention. Next, we'll explore the abnormalities detected in the mitral valve, a crucial valve controlling blood flow within the heart. The mitral valve. A story of unusual placement and function. The mitral valve, typically situated between the left atrium and left ventricle, presented with several notable abnormalities. Instead of its usual position, the mitral valve was found to be tricuspid, meaning it had 3 leaflets instead of the typical 2. Furthermore, it was septophyllic, meaning it was positioned closer to the interventricular septum, the wall separating the ventricles. Adding to the complexity, the mitral valve was apically displaced, located further down in the ventricle than its normal position. This unusual placement can disrupt the normal flow of blood from the atrium to the ventricle. The echocardiogram also revealed a calcified mitral annulus, the ring of tissue surrounding and supporting the valve. Calcification can stiffen the annulus, potentially hindering the valve's ability to open and close properly. Finally, the mitral valve exhibited moderate stenosis, a narrowing that restricts blood flow through the valve. This stenosis could further compromise the heart's ability to pump blood effectively. Having examined the mitral valve, we move on to the tricuspid and aortic valves, looking for additional clues in this complex cardiac puzzle. Conclusions. Ventricular ejection fraction 35 to 40%, globally dilated and hypokinetic. Large VSD, functionally single ventricle with double inlet. The morphologic tricuspid valve is on the left side mitral position, septophyllic, apically displaced, prominent chordae to left-sided papillary muscle, calcified annulus and leaflets with moderate stenosis. Pacemaker wires seen crossing the right-sided AV valve, morphologic mitral valve in tricuspid position. Prominent left-sided moderator band. Pulmonary valve is mildly stenotic. Left-sided aortic arch. Atrial situs solitus, appropriate anatomic position of morphologic left atrium and right atrium. No significant flow seen across the atrial septum.